Welcome again to another episode of Monitor Your Health, the program where we educate the public about contemporary medical issues. Today, we have another topic which is quite important. Is a topic or a disease that I've known right from I was little till now. It is malaria. And for us to discuss malaria today, I have with me Professor Mokuolu. You're welcome, sir.
Thank you very much, and good morning to everyone.
Good morning. Please, can you introduce yourself to our viewers?
Okay, my name is Olugbenga Mokuolu. I'm a professor of pediatrics and a consultant pediatrician at the University of Ilorin and its teaching hospital. I'm currently the National Malaria Technical Director with the National Malaria Elimination Program. And I work in the field of malaria and does some extensive consultation for the WHO and several other international agencies in the area of malaria, especially malaria case management. Thank you.
Thank you so much for giving us the opportunity to tap to your wealth of experience. Now, malaria is a disease that I've grown up to know right from little till now. It seems to just continue to stay in in front of us everywhere we go. And I think from what I gathered, it's actually one of the reasons why the colonial masters couldn't stay long on our land. Perhaps is the main thing or main reason why we still have our country to ourselves. So, how bad is the case of malaria? What is the burden of malaria in Nigeria?
Yeah, so thank you very much. I think out of every adversity, sometimes we have something to rejoice. So I guess we probably owe it more to Nigeria, to malaria, that we have in Nigeria. Otherwise, probably other people will have settled here very well. Overall, we've made progress. I want to consider malaria sometimes in terms of phases. There's what you want to call the dark ages, when we basically dropped in the dark. We didn't understand what the disease was, what was causing it, and this was a global phenomenon. Everybody was in the dark, almost to the extent that, in fact, today we are doing far better with COVID, but there were generations, thousands of years of being in the dark about malaria. Then we had some light and optimism. Okay. Unfortunately, we actually didn't know the nature of the enemy we were dealing with. And after that period of optimism, we are now probably in the era of some form of reality. But be that as it may, we've then made progress over time. So if you were discussing this some 10 years ago, probably I'll be telling you that globally there are about 500 million cases of malaria that does occur each year. But currently, the World Malaria Report 2019 informs us that annually we now have about 228 million cases of malaria. But the challenge with that, unfortunately, is that Nigeria alone as a country contributes 1/4 of that number. So we have about 53 million cases of malaria occurring in Nigeria annually, and that's quite enormous. So this is why the global body has come up with a concept of something known as high burden, high impact, in which 10 countries of the world plus one Asian country actually account for nearly over 80% of the global malaria cases. And you can understand that if Nigeria alone contributes 1/4 of that burden. Now, if you go on from there, we have about 405,000 deaths occurring from malaria annually. Again, Nigeria contributes about 1/5 of that number. Okay, so we have about 80 to 82,000 deaths, okay, occurring from malaria annually. And maybe to bring home what it means when we say 405,000 deaths, just imagine an aircraft that can take 300 people. You need 1,300 crashes of those type of aircrafts occurring each year. That is the number of people dying from malaria generally. And Nigeria has 80,000 of that, of the deaths occurring annually. So that's how big, but despite this gory picture, it's likened to somebody who was trying to report about the progress of his life and who showed that he used to smoke different types of injurious, harmful substances. And people then noticed that he was still smoking something. They say, yeah, that actually he used to smoke something worse than this before. Okay, so as bad as this is, it actually represents progress that we have made in recent times. For instance, from year 2000 to 2015, we've been able to reduce the incidence of malaria by 41%. In 2010, the prevalence of malaria in Nigeria was 42%. In 2015, this had come down to 27%. In 2018, this is 23% or 22% thereabout. So we are making progress, okay, but we are far from where we ought to get to. And unfortunately, malaria is not like a building. Even a building that is made of solid materials, when you abandon it, it begins to depreciate. But for malaria, if you stop what you are doing, it goes right back to the kind of figures that kept the adventurers away from Africa. So that's the challenge that we face. So we must sustain the pressure on malaria.
Wow, that's a huge burden. Looking at the number of lives that this, terrible disease actually, claim every year, that's really, bothering. Now, I sometimes think, I sit down and think about this disease. Since I was little, I was in the medical school, went out of medical school, and still around here, it's still causing a lot of havoc. Why is that? Why can't we just get rid of malaria outrightly?
Yeah, so that is the thing I said about the age of reality in which we are. I remember reading from some of the works of Ronald Ross, who is one of the founding fathers of present-day knowledge of malaria. And he was exasperated, and they describe it as this little bug that comes around and kills in millions. Okay, so there's this thing about it. Malaria is more than a cat with 9 lives. And the key strategy is the fact that it's been wise enough as a disease to partner with a third party, okay? And that is the mosquito, all right? So the fact that it is not just simply direct from me to you, but goes through a third party who is able to continue to deposit it everywhere, it's part of the special wisdom of this disease, okay? And so the first thing in overcoming your enemy is a healthy respect for the enemy. And unfortunately, it is one of the most underestimated diseases, okay? But if you think about it, just a rough analysis, and you ask yourself the question, the smaller organisms are
Okay, we have some challenges with the network again. So
the more devastating consequences. Now, think of because of elephant attack. Okay.
Okay, I think you're back now, sir.
Yeah. Okay. So if you take a lion, as deadly as a lion is, maybe they kill in some few hundreds, okay, depending on how people wander into their territory. But when you start coming to bacteria, okay, you see the number of people devastated by bacteria. You go to a parasite like malaria, it kills much more. You then go to viruses. So there is this thing about nature that the smaller the attacking organism is, the more devastating the consequences are. And I think one way is to show a healthy respect to malaria. COVID is also out there today. People ignore it at their own peril. Okay, so that's one. Number two is that, as I've said, actions against malaria must be sustained. It must be concerted. It must be strategic. It must be sustained, and it must be in an available quantity to bring about the desired impact. So if things are sporadic, they will become inefficient. All right. So that's part of the reason for the seeming persistence of malaria. Although, as I keep saying, we're making progress, but we're not there yet. I hope I'll still have some further time to talk about the efforts towards control.
Yeah, sure. Thank you so much for that, sir. I think there's a lot to talk about the that control aspect of things, because even me, I have more questions to ask. But let's pack it for now so that we can also answer some of the salient questions that people from the public had already asked before. So we know that COVID is here, and there's been a lot of whether conspiracy, whether it's true, but we have theories where people come up to say, well, there's no COVID. What we have here is malaria. People are the government is just trying to look for a way of bamboozling us. So if one has malaria, how do one know that they actually have malaria? And how does that differ from COVID?
Yeah, so like many conditions of ill health, there are what you call overlapping features. Okay, ever before the arrival of COVID, we've always known that conditions have characteristics that look similar. Okay, let me just give you this typical example. If people are football players, you might just say a player is a player. But why does somebody play better in the attack, another plays better in the defense? It takes another level of skill to see that a player has some characteristics going forward and another player has characteristics defending from behind. Okay, that's another level of skill. But to the uninitiated, a player is a player, a footballer is a footballer, and it's difficult to tell the difference between one and the other. In the same way, many conditions will present with a fever, for instance. Fever is a common expression to many disorders. And so, unfortunately, in COVID, there is fever. In malaria, there is fever. In typhoid, there is fever. In pneumonia, there is a fever. In urinary tract infection, there is a fever. Okay, so that's the first problem. The other issue is that until you get to a critical point, in malaria as well as in COVID, you could have this fever without being otherwise significantly very ill, at least at the initial stages. So both of them are just fever and you are still moving around. All right. So this type of overlap is part of what people are misunderstanding. A third point of misunderstanding that has occurred is because one of the potential drugs that has been identified to be of value in COVID happen to have its origin in the treatment of malaria. But there are many things. Today, for instance, one of the instruments that is used in the lab to test COVID was designed for testing TB, tuberculosis. And that instrument now is adapted to be able to test for COVID. So in the same way, in the evolution of knowledge and science, there are many things designed for a particular intention, only for you to find out, either accidentally or somehow fortuitously, that it can also perform another type of function. So hydroxychloroquine and chloroquine, for instance, were found to have some viral suppression effect against the corona class of virus. These are things already published since 2005, 2003, ever before we started talking about the new COVID virus. So now that we have a new COVID virus, one of the things you do in life is that when you have an unknown situation, you start from what you think you know, and begin to explore. So in searching for solution naturally, one of the first places they started with is to go back to this known characteristic of this drug and to start at least exploring it, pending when some better information is available. So when people are being treated for COVID and they needed to be given an hydroxychloroquine, for instance, or chloroquine, they are not being treated for malaria. They are being treated for COVID on the strength of the understanding that is available. Now, whether that is proven conclusively or not may be the subject of a different debate, okay? But understand that COVID is real, COVID exists, but COVID presents in a manner similar to malaria. And this is the whole reason why in medicine, you talk about differential diagnosis. It is because symptoms overlap. And then you now need certain things. And if you cannot tell the difference clinically, you finally resort to a test. So how do I know I have malaria? It is by testing. It is by testing. And it is better that once you have a symptom of fever, especially in this era, and in order not to delay the onset of the treatment of a more deadly disease, you should quickly get yourself tested so that if it's malaria, you're on the right treatment. And if it is not malaria, then you don't waste too much time. You can begin to focus on what those other alternatives can be.
Thank you so much. That's quite elaborate, and I hope that viewers can, gain one or two things from this discussion, because I've seen loads of people coming to say, "Oh, there's no COVID. It's all malaria," and it's they've talked about chloroquine and things like that. So please be cautious. COVID is here. Malaria is malaria. COVID is here. Okay. Now, so Sam, now, you talked about you mentioned chloroquine, and I know that, there are various type of treatments that exist. Because you mentioned chloroquine, I just want us to explore this area a little bit. Some people till now, they still believe that chloroquine is the only treatment for malaria that works for them. What's your view about this? And what are the treatment options that we have available?
All right, thank you very much for that question. So to the audience, let me just, viewers, let me let you understand this very quickly. We have a system of assessing which drugs works for malaria. And we do that as a continuous check. And prior to year 2000, it was becoming obvious that chloroquine was failing. And long before that, in other climes like Southeast Asia and all that, maybe some 10 years before then, chloroquine had actually failed permanently in those places. But there was still some sanctuary of sensitivity coming towards West Africa. I used to say that Nigeria was like the last sanctuary, actually, for the efficacy of chloroquine. But at about this period, we also began to study. And then we realized that chloroquine has failed to the extent that on a national average, it recorded only 34% efficacy. 34%. We don't use that type of figure to treat anybody, all right? We currently, as we stand today, any drug that cannot achieve 90% efficacy must be withdrawn from the treatment list, okay? So as at 2000, between 1998 and 2000, we were already demonstrating that chloroquine was efficacious only up to 34%. Sulfadoxine pyrimethamine at that time, which was not even in common use, was failing at the level of about 57%. So it already shows us that that is not the alternative for us to go to. So collectively, the global body came together and they saw that there is a common trend that every time we have used a single drug to treat malaria, there will ultimately be a resistance. And that was why there was a fundamental shift. It no longer even has anything to do with the efficacy of that drug now. That is a fundamental shift, that we no longer use one drug to treat malaria, but a combination of drugs. And so we have moved from monotherapy to combination treatment. So on two grounds, why you no longer use chloroquine, it is no longer sensitive, and we have shifted to combination therapy. The third thing that causes confusion for people is that chloroquine, just as you are seeing expression against abscess, chloroquine has an antipyretic effect. That is, it works against fever, and it also is generally an anti-inflammatory. So you still see chloroquine being used for rheumatoid arthritis and being used for some conditions like systemic lupus erythematosus, and those type of what we call connective tissue disorders, okay? So irrespective of what you are treating, when you take some chloroquine, the fever goes down. And the person comes under the false impression that his malaria is cured. And it became acceptable to us to be treating malaria every 2 weeks. And so you see people expressing themselves, say, me, I have malaria like every month, every 2 weeks. And it looked fashionable for you just to be swallowing drugs to treat malaria, because all along, you were never given something that was effective. And it was having cumulative effect. When eventually the effect becomes devastating, we will not appreciate that it's been because of failure of sequential treatment that has brought us to that particular point. So I want to say it categorically that if you are still using chloroquine as your primary drug for the treatment of malaria, you are not doing yourself well at all.
Thank you so much. Before I go to my next question, there's a question that was just been asked by one of the viewers. So she said, or he or she says, some doctors go ahead to prescribe malaria drugs for patients who visit the hospital even before tests are carried out. What's your view on this?
Well, the national policy and treatment guideline by the government of Nigeria, and also as adapted from the WHO recommendation, is that we need to test before we treat. We need to test before we treat. And we no longer really have excuse for not testing, because we now have the rapid diagnostic test kits,
Right.
which that's the RDTs, which gives you a test result within 10 minutes. Okay, and you can see the result. The patient can participate in understanding the result of that test, and it gives everybody more confidence. It's not subject to intra-observer bias, the way you will have maybe with a microscopy. So in the very least, you should be able to get an RDT done before treatment. As we have said, the benefit of this is twofold. One, confidence on what you are treating. Two, early alert that this is not malaria, so you don't sit over another devastating illness and you are continuing to treat malaria. It is for your own benefit. Actually, let's empower the people, demand that you get tested before you get treated.
Thank you so much, sir. And on that note, talking about the RDT, how reliable? How reliable? That's one question. The other question is, how reliable is RDT? That's the first question. The next question I want to ask, so that you can probably answer the two together, is how available are they as well? How is readily available are they?
Yeah, RDT is a very simple test. They are readily available and they are reliable. Okay. Any health facility, an appropriate health facility that is offering malaria treatment should have RDT. RDT has been made in order to improve access to testing. Before, we only had microscopy. So you needed the microscope, which is capital intensive. You needed training over a long period of time and sophistication before you can perform a good quality microscopic examination of the blood to dictate whether there is malaria or not. And that is almost the exclusive preserve of a very few number of trained laboratory personnel. Okay, but the RDT has been designed to overcome all of those shortcomings or challenges, and they are actually to be deployed in the absence of microscopy, in the absence of any skilled person, and to put it in everybody's hands. And through the efforts of various international partners supporting the federal government, there has been, massive access to RDT, which is made available in several of the primary healthcare centers. I mean, these are the kind of places you will go and you think that there is no diagnostic capability. And even in private settings, RDTs are certified upon importation in the country. They are batch certified, and so they are reliable. Now, the thing, so they are available. Talking about reliability, the first issue is this. Let me appeal first and foremost to the top echelon of maybe even the medical practice. RDTs confront us with a reality that challenges our practice over time. Normally, if you don't test, there's a tendency that maybe out of every 10 fever cases that present to you, about 8 of them will be treated for malaria. When you start testing, you may find probably only about 3 or 4 being positive. So you see, it tends to challenge a practice that you have established, treating most people for malaria. And so many of my colleagues in the senior bracket will tend to put the blame on the RDT and say that this RDT is not reliable because it's not returning as many positives as they think they should have. Meanwhile, RDT is only telling them the truth. Okay. In some other cases, you have issues of people who are a bit stuck on microscopy, and there is a tendency again to discredit the RDT. The RDTs are extremely reliable. They are not screening tests, they are diagnostic tests. okay? Just as microscopy is diagnostic. So every test may have its limitation, but they are also diagnostic, okay? So they are reliable, they should be pursued, and it's better to have them within the chain of our activity so that we know exactly what we are testing.
Thank you so much, Prof. There is one question here, I think maybe from a colleague by the sound of it. This said, looking at RDT, I have seen a patient tested negative on it, but tested scanty malaria for the lab.
Yeah, so that is one of the most horrific scenarios.
Mm. Okay, so we've lost Prof there, so we'll wait a little bit. Probably he's going to join us in a minute. So good morning again, everyone. We have been discussing, malaria, and we have on the program Professor Mokuolu to enlighten us about malaria. So we have been, okay, I think Prof is back. Hello. Okay, yeah, he's back. You need to unmute yourself, sir.
Okay.
Yes. Okay.
Sorry about that. Yeah.
It's all right.
So,
yeah.
So the issue about microscopy is that it is expert microscopy. Expert microscopy. I have seen too many errors of microscopy results that really I would rather do an RDT most of the time, except I know about the quality of the person who is doing the microscopy. So RDT, and then when somebody says scanty, yeah, on microscopy you could see one or two things, but when they use that word scanty, it doesn't connote confidence. Okay, it doesn't connote confidence. You really don't know what that means. It's equivocal in many cases. All right. So I think the overall issue is that you put your patient in context, okay, and all of that. And let me say this to us, maybe it may reassure us. The mechanism by which the most common RDT we use, not all, but if an RDT belongs to the class of what we call HRP2 antigen RDT, okay, that is histidine-rich protein 2, okay? Those type of RDTs, the histidine-rich protein 2 is just on the wall, on the body of the parasite. So even if the parasite is dead, that test continues to be positive for a while. And it can take up to 4 weeks to remain positive. That is why we don't use RDT to monitor response, except an RDT that is based on another mechanism, like the one that produces the lactate dehydrogenase enzyme, okay? So those ones, once the parasite is dead, the enzyme is no longer produced. What am I driving at? The tendency for an HRP2 RDT is to exaggerate positivity. So when it is negative, it is actually truly negative.
Right.
Because it exaggerates its positivity a little bit. And it doesn't mean it is false positive. It just means that both dead and living parasites are equally identified as, positive. So if it has that capability, when it now says negative, you really, really, really want to be clear that it is negative. And I can say to you, without any contradiction, that it does this significantly up to parasite levels that are very low as maybe about 200 parasites per microliter of blood. And yet, the person who has malaria tends to manifest malaria when parasite level is about 2,000.
Wow.
So by the time you have it as the symptom, a negative RDT is not possible when you still harbor the parasite in your blood. The only reason that makes it potentially possible is the infinitesimal possibility of something we call HRP2 deletion. But I don't want to confuse the audience with too much technicalities here. And the proportion of that occurring is very small. It doesn't invalidate our test significantly.
Right. Thank you so much for that. Yeah, this same question, the person that asked the same question, ask another question, another layer on top of this, saying, so are you saying that when a patient have a scanty malaria, chemotherapy shouldn't be carried out?
So what I'm just saying is that the first context of that question was using it as an expression of superiority over RDT. And that is making me to query that result fundamentally. Okay. Now, on a standalone basis in itself, from scanty to plus, four pluses, or any of those issues, what I'm just getting at is that malaria microscopy is dependent heavily on the quality of the microscopist. So if you are in any organization, you should make it a demand that your microscopist undergoes the appropriate quality training periodically. That somebody just comes with a certificate of being out of a school of laboratory technology or any other type of training does not mean that they do not require that further expert training. In all our schools, we are all trained generally. So as a medical doctor, you go through internship and then you begin to hone your skills a lot better. In the same way for our laboratory colleagues, you have your basic training, but then when it comes to certain things, you need to hone down on them and have those skills refined. So when we say microscopy, we qualify it and we say expert microscopy. I've had situations where I was being given some irreconcilable microscopy results in the care of the newborn. And I've gone to the laboratory and we were getting those results almost on a weekly basis. And that all our newborn were getting positive. So I had to go to the lab. We sat down together. We checked what was being called positive. Okay. And at the end, we convinced ourselves that maybe there is some inadequate judgment here and all of that. And pronto, those type of results disappeared from what we were getting. So we all need this feedback with one another. So scanty, if the person sees something small, it's important, but we need to be sure that it's not somebody who has just expressed that in a way to play safe, even when he has not particularly seen something remarkable. Yeah.
Thank you so much. But that question, the second bit of that question, I don't think it's been expressly answered yet. So do we, in cases where they have this scanty results, so what we're saying here is they should use the clinical judgments to also back their, or
at all times. But the patient always get the benefit of the doubt.
Yeah.
So treat, all right? Treat. But I'm just telling you what you do to ensure that you continue to have confidence in your results. We also don't want to encourage a practice where people willingly continue to overrule the laboratory result on clinical judgment. Then why do the laboratory tests? Okay, so we must have quality assurance methods to make both parties to accept the results that we have.
Okay. Thank you so much, sir. So now I'm going to go on to the next questions that I want the public to ask, and then I think we need to trash here. There is a question around the Sunday treatment. When I was growing up, I remember my mom every Sunday, she will hit all of us with, with a prophylactic medicine against malaria. Does that still exist? And does it work? So that's the question.
Yeah, so let me say here that that drug is pyrimethamine, which then was being marketed as Daraprim.
Yes.
From the point of its ability to prevent malaria, it has recorded 100% failure. Okay.
Whoa.
So it's of no use. And so we don't recommend its use. Rather, we encourage such practices like the use of insecticide-treated nets, sleeping under the insecticide-treated nets as the key as the key method of trying to prevent malaria. For pregnant women, we have additional actions that we take. And for some of our children under 5, especially in the northern parts of the country, we also have additional measures that we are introducing to protect them from malaria. So, but categorically, no place for Sunday medicine. It's 100% failure in preventing malaria.
Wow, thank you so much. And what are the roles of things like the rate, shell, all this Baygon and all this insecticide that we use, obviously in preventing malaria?
So our attitude to them is like maybe sometime when you use multivitamin, okay? Yes. whether it increases your appetite or not, I know that when you are hungry, you will have your appetite increase. So the thing is that they have some little effects, but not to the dimension that will make us recommend them as any partial area of main strategy of prevention or intervention. For instance, if you take the bracelets, there is this bracelet that became very popular of recent that they were talking about. Yeah, so those bracelets create a zone around them, okay? And you can just imagine that I wear a bracelet on my hand and I have a radius of an area of that bracelet that is protected. My head is there, my abdomen is there, my leg is there. I mean, what's the benefit of that? So, but you can consider some of these things from the point of personal protection, and their effects are so short-lived. At times, you will fleet your house, and when you go outside the room, you wait for 30 minutes, you come back, and then by the time you open your doors, things are still there. The reason is that when we talk of indoor residual spraying is not the use of this small canister of insecticides that people spray in the house and all that, okay? So they have some little effect, but they are not the mainstay of our preventive strategy. Because when you do indoor residual spraying, the normal one leaves its effect on the wall of the house. And because the biting habit of the mosquito is that after biting, it goes to rest on the wall, then it will pick the insecticide at that time, and the insecticide will kill it. And for a proper indoor residual spray, that effect can last about 6 months before you reapply it. So all these shelters that you just put 1 second in the air, and so I think they just treat us psychologically.
Wow, thank you so much for that. Somebody asked,
might add that for some of those things, they have other pest control benefits that you can use them for cockroaches, a few other things. Yeah, so I have no problems with that.
Right. So somebody asked a question, can Prof please provide the extra measures in preventing malaria in pregnancy?
Okay, so for the pregnant women, we also encourage them to use the insecticide-treated nets. Then we add something that we call intermittent preventive therapy. That is giving the pregnant woman treatment doses of sulfadoxine pyrimethamine. I can't mention any proprietary name here, but sulfadoxine pyrimethamine. So they take 3 tablets of that, separated by each month after the period of quickening, anywhere from after 18 to 20 weeks of pregnancy, okay? And we use quickening because at that point, you are feeling the baby kick. And by the time you do that, you are clearly outside the first 3 months of pregnancy, during which the use of such a drug will interfere with the development of the fetus. Okay, so, but once you get after the period of quickening, and then you take it the pregnant woman takes it every month until the last month before delivery. And that has been shown to significantly help, particularly with placenta parasitemia and several of the outputs in terms of maternal anemia and fetal birth weight and newborn birth weight and the newborn Apgar scores have all been shown to improve dramatically, especially if you're able to take 3 or more doses of that in pregnancy. So 1, the NET, 2, the SPI-PTP in pregnancy is the approach that we use for pregnant women. And we really want to encourage this for pregnant women themselves to begin to make a demand for this wherever they are receiving the antenatal care from. It is very beneficial.
Thank you so much, sir. So in the first trimester, how do we manage in case?
No, so just as a habit, a woman of reproductive age should please sleep under the net.
But in a situation where they come down with malaria.
No, so the IPTP is not to treat malaria, it's to prevent it. So when they have malaria, then we use the regular treatment for malaria as prescribed by their physician.
Okay, thank you. This person is really going on for this. He's asking, how common is fetal-maternal transmission of malaria?
Yeah, so it's okay. I'm comfortable with that. We led the study on epidemiology of congenital malaria in Nigeria, and we looked at 2,800 mother-baby pairs across 4 centers in this country, and we were able to establish a few things. Number 1, we saw that peri-delivery, about 17% of the women were positive for malaria as of then, when the study was done. Okay. Secondly, we saw that in first and second pregnancies in particular, there was a significant multiple-fold likelihood. First and second pregnancies were more likely to come down with this malaria around pregnancy in the pregnant women, but the transmission directly to the babies was actually very low, which suggested that the placenta in itself acted as a major sieve. But even if the direct transmission to the baby was low, the consequences to the babies were still there. There was a higher proportion of preterm delivery. There was also a higher proportion of low birth weight. And
okay, so the network is fluctuating again. Again, we are just we're talking about malaria. We have Professor Mokuolu enlightening us on malaria. We're just about to answer a question around the transmission from mother to baby, and we just have a bit of
okay, allow me to.
All right, you're welcome back, sir. Oh, hello. Okay, so I think Prof is gone off a bit. So
Hello.
Oh, okay. Hello, sir. You're still on.
I change. Let me take off internet.
All right. Internet. Okay.
Let's
So we.
change to what? Okay. All right.
Yeah.
So yeah, let's go on.
Okay. So yeah, we can hear you now.
Okay. Okay. Yeah. So the proportion of those pregnant women that were anemic was equally higher. So what we found actually was that direct transmission to the babies causing malaria in the baby in what we call congenital malaria was very low, very, very low. But then it also brought up two other things. One, there is that potential, no matter how remote, and then the fact that newborn babies, even within the first month of life, who have malaria was also made manifest. And so there is a place for you to consider malaria in the evaluation of a newborn baby who presents with fever, especially those who are coming in from the second week of life. Okay, but in the first week of life, if you see malaria in a newborn baby, we call that congenital malaria. But as I said, the transmission rate of that was really pretty low. And none of those who had that directly were became symptomatic, really. So it was something that was very interesting. In fact, in the study, we had a particular slide. If you allow me to exaggerate a little bit, if you stretch your naked eye, you could almost see the parasite on the slide in the placenta of that mother. Everywhere was riddled with the parasite. And the baby was clean, 100%. We looked and looked and looked and looked because it was so surprising. And it's one of those reasons to believe that the placenta is a partial seal. But you see, malaria is sequestrated in the placenta. So it also blocks blood flow. So even if the parasite doesn't get transmitted, the consequence of reduced blood flow through the placenta still tells on the baby. And that is why this must be cleared.
Thank you so much, sir. So usually we run this program for about 45 minutes, but there's been a lot of questions and I think we keep going. So I know I was warned. So we have one question here now. Says, please, sir, would you be, what would be your advice on how the country can manage and possibly curb malaria being an endemic country? That's question number one. Effort has been made and are ongoing. However, the disease continues to be a menace.
Yeah, so well, that is partly my current job. I told you I'm the National Malaria Technical Director. So there are different layers of intervention. First, we look at it from the technical aspect. So in any logic, to have a logical sequence of thought, we think about it in terms of prevention, we think about it in terms of treatment, and particularly avoidance of mortality. Okay. So from the point of prevention, let me say that overall, the ultimate response is multisectoral. Evidence is now showing that urbanization contributes rapidly to malaria reduction. Okay, so the more we take the national developmental agenda seriously and have better housing, better roads, better drainages, better waste disposal practices, all of this will have broad ramifications on malaria. So we call something social determinants of health. And I want to emphasize it over and over and over again that development is critical, okay, in this regard. Now, having said that, Then when it now comes to other direct vector control measures, we encourage the use of the long-lasting insecticide-treated nets. I want people to have confidence in this intervention. They say that there is heat when they sleep under it and things like that. But I asked some people a question recently. Supposing they say to you that sleeping under a net will prevent you from having COVID-19. I'm sure people will ensure that they sleep under 10 nets at the same time. So it's a perception. It's a perception. I think we're taking that solution for granted. And these nets have insecticides upon them that last 3 years. So you don't have to keep changing. The market for it is subsidized. The government every 3 years, irrespective of your state, tries to ensure a replacement of this net. So either from government or from your own personal efforts, you can afford one net in 3 years, okay, to sleep under. That is very important. As a person, take charge of your own personal environment as well, okay? Your house, your drainages, everywhere around you. Those age-old practices still have their place. And of course, our houses are built, they are well screened, and all those measures. Okay, so that is one. Then in the area of treatment, when you test before treatment, we have a more accurate record on our database. Some of the fact that we keep saying this problem are persisting, the people who are estimating the burden of the disease are constrained to continue to estimate because of lack of reliability of available data. And when you continue to estimate, it will be difficult to estimate zero, except when you have done proper measurement and you see zero. Okay, so this is why all of us must embark on the practice.
Okay, so the network keeps fluctuating again. Right, so we just lost Prof there. Hopefully he'll be back. We're still talking about malaria and talking about what are the measures that we can put in place as a nation to to reduce the burden of malaria in Nigeria. So we're hoping that we get Prof back in a short while. Right. Okay. All right. You're back, sir?
Yeah, sorry about that.
It's
okay,
all right.
So I just think about the role of testing, though it might not be seen directly related to control, but testing gives us better data. Then the use of ACT, it has the dual benefit of curing the patient and contributing to clearing that aspect of the parasite that is responsible for facilitating transmission. So when you use ACT, fine. Then thereafter, if for any reason somebody has the severe disease, we use injection artesunate and other supportive care. And this has been shown to be superior to quinine, to be superior to artemether. They are not in the same class in terms of efficacy in treatment of severe malaria. Okay, so artesunate is the drug of choice for severe malaria. Now, I want to come down to suggest that we say to everybody, we also need to take personal responsibility. Just imagine if I keep my system clean by taking my personal actions that I need to take. Even if a mosquito visits my blood, it will have nothing to transmit from me. Okay, so can we take on that personal duty of keeping our own system clean, such that it will not be from me to another person? The more we all take this level of responsibility, the more we are part of the solution. Okay, so these efforts are going on. Innovations are being looked at currently as we are speaking. there is an evaluation of innovations around the country, just to make sure that anything that is hidden, which somebody has discovered somewhere, can be brought to light.
Nice.
And we can examine whether we can have more tools to deploy. Okay, but again, malaria requires sustained effort. So what we are doing is working, but it must be sustained. We also need increased government funding. Malaria as a condition, if no matter how we're doing the planning for the country, if a country causes the amount of problem malaria causes, then it should receive its own heading in the national funding. Okay? Look at what COVID has done now. Hasn't the government diverted resources to COVID to the extent that we saw it as a problem? But if you look at the figures of malaria deaths that I've mentioned, COVID deaths is still less than 1,000. And we pray that it will remain low. We don't wish anybody die. But the question is, in as much as we don't want people to die from COVID, they should not die from another condition. So what we want is for a Nigerian to survive completely. Okay, so conditions that have this type of high fatality rates, okay, need to be specially funded as the critical emergency fund. It's not until we have insurgency or have one other crisis or the other before we start voting money. We are talking of building a system. Yeah. Okay, so everybody has a responsibility. The government has its, we the practitioners have ours, individuals have theirs. Okay, and it is everybody's collective participation that gives us the solution we desire.
Wow, thank you so much, sir. So it's been a very, an hour of real education and around malaria, and we really appreciate you, sir, for giving us the time. We'll be rounding up now. However, I just want you to I know you've just wrapped up on what you think we should be doing in the country, and sitting in the position where you are, you see better than most of us. If I want to ask the last question, say, what can you see? What's the horizon looking like? How long are we going to be in this for? From your own point of view.
Yeah, so I've had to deal with that a number of times. What I see ahead is a choice. Possibilities lay ahead of us, but the choice is ours. If we choose to continue in doing what is right, we'll get it right. But if at any point in time we deprioritize malaria, then we'll get the consequence. It's as simple as that. The tools available and the trajectory that is before us says to us that we can eliminate malaria. We can, but it's a choice. Sustained, concerted effort, everybody getting involved will take us to that destination. Lethargy, lukewarmness, deprioritization will put us in a reverse gear. It will not leave us where we are. It will put us in a reverse gear. So what is ahead of us is really a choice. We can win, we can lose. It's all a matter of choice.
Thank you so much, sir. And on that note, I'm going to just thank everyone that participated. There are more questions coming up. I will be answering those questions, offline. But we really have to go now. Otherwise, we'll be here, much longer. So I really thank you, sir, for giving us the opportunity. It's always a pleasure. Professor Mokuolu was my best teacher when I was in medical school, and I really, you're one person that we all look up to, and the position that you've been, we pray that God will keep you there for us, and then we always continue to tap, to the wealth of knowledge that you have. Thank you so much for coming this morning.
Thank you very much. It's been my pleasure.
Thank you, sir. And to the audience, thank you so much for joining again today. So we look forward to meeting you again next week when we bring up another exciting topic. Please share this video, let people learn from it, and then have the best of the weekend. Bye-bye.